Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training, and I want to welcome you to this solid anatomy lecture on the cranial nerves. And in this video, we're going to be covering cranial nerves 7 through 12. We covered 1 through 6 in our previous lecture, and now we're going to do the 7 through 12. Now, I'm going to be back later for some clinical correlations and the end-of-session quiz, but for now, I'm going to turn it over to our primary lecturer, Dr. John Phelan.
Cranial nerve 7, the facial nerve. The facial nerve carries nerves of 4 different modalities: special visceral afferent, general somatic afferent, special visceral efferent, and general visceral efferent. The facial nerve has 2 parts, a motor root that is sometimes called the facial nerve proper, and the nervus intermedius. The nucleus of the motor root, called the facial nucleus, is in the ventrolateral part of the pons. The motor root is involved in the motor innervation of muscles that develop from the second branchial arch. The nervus intermedius carries the other 3 modalities. The cell bodies of the parasympathetic fibers are in the superior salivatory nucleus in the pons. The nucleus of the taste fibers is in the solitary nucleus in the medulla, and the general sensory fibers, which supply some of the skin on the outer ear, synapse at the trigeminal nucleus. Both parts of the facial nerve emerge laterally from the brainstem at the border of the pons and the medulla and enter the internal acoustic meatus. The facial nerve has the longest interosseous course of any cranial nerve. It passes through a Z-shaped canal in the temporal bone, usually called the facial canal, which begins at the internal acoustic meatus and ends at the stylomastoid foramen. The facial nerve begins its course running laterally, then takes a sharp inferior turn. The point where the nerve changes direction resembles a bent knee. Thus, it has been named the geniculum. This is the site of the geniculate ganglion, the sensory ganglion of the facial nerve. Cell bodies of the taste and general sensory fibers reside in this ganglion. The first branch of the facial nerve, the greater petrosal nerve, which carries preganglionic parasympathetic fibers, comes off near the geniculum. The greater petrosal nerve leaves the facial canal and enters the middle cranial fossa, passes anteriorly across the foramen lacerum, where it is joined by the deep petrosal nerve, a postganglionic sympathetic nerve. These 2 nerves continue anteriorly. The greater petrosal and deep petrosal nerves then enter the pterygoid canal as the nerve of the pterygoid canal. The pterygoid canal opens anteriorly into the pterygopalatine fossa, where the nerve of the pterygoid canal enters the pterygopalatine ganglion. The deep petrosal nerve does not synapse here, but the greater petrosal does. Its postganglionic parasympathetic fibers go to the mucous glands of the nasal and oral cavities and travel with the zygomatic branch of the maxillary division of the trigeminal nerve to reach the orbit, where they ultimately supply the lacrimal gland. The facial nerve takes another inferior turn within the canal and gives off the chorda tympani branch, which carries preganglionic parasympathetic fibers and taste fibers. The chorda tympani traverses the tympanic cavity and passes through the petrotympanic fissure between the petrous and tympanic portions of the temporal bone to reach the infratemporal fossa. It then joins the lingual nerve, a branch of the mandibular division of the trigeminal nerve, and travels towards the oral cavity. The preganglionic parasympathetic fibers in the chorda tympani synapse at the submandibular ganglion, which is suspended from the lingual nerve. The postganglionic fibers are secretomotor to the submandibular gland and the sublingual gland. The taste fibers in the chordotympany nerve continue to run with the lingual nerve to reach the anterior 2/3 of the tongue. The facial nerve finally leaves the skull through the stylomastoid foramen, gives off a posterior auricular branch, which supplies motor innervation to the occipitalis and intrinsic muscles that wiggle the ear, gives motor branches to the stylohyoid muscle and the posterior belly of the digastric muscle, and enters the parotid gland. Within the gland, the facial nerve divides into temporal, zygomatic, buccal, mandibular, and cervical motor branches, which innervate muscles of facial expression, such as the orbicularis oris. Cranial nerve 8, the vestibulocochlear nerve. The vestibulocochlear nerve separates into a vestibular and a cochlear nerve after emerging from the junction of the pons and the medulla and entering the internal acoustic meatus in the middle cranial fossa. Both of these nerves are special somatic afferent. The vestibular nerve is associated with body position and balance, while the cochlear nerve is involved with hearing. Central processes of the vestibular nerve synapse at the vestibular nuclear complex in the medulla and in the cerebellum. The cochlear nucleus is in the medulla. The cell bodies of the vestibular nerve are in the vestibular ganglion, which is found within the internal acoustic meatus. Their peripheral processes end in receptors in the semicircular ducts, the utricle, and the saccule, which are sensory organs found within the temporal bone in the tympanic cavity. The cochlear nerve's cell bodies are in the spiral ganglion, which is found within the cochlea, another sensory organ of the inner ear. The peripheral processes of these cell bodies synapse with hair cells in the organ of Corti, which is also in the cochlea. Cranial nerve 9, the glossopharyngeal nerve. The 5 modalities carried by the glossopharyngeal nerve are the special sense of taste to the posterior 1/3 of the tongue, special visceral afferent. General sensation to the posterior 1/3 of the tongue, the oropharynx, and the carotid sinus, general visceral afferent. General sensation to part of the external ear, general somatic afferent. Motor innervation to the stylopharyngeus muscle, special visceral efferent, and parasympathetic innervation to the parotid gland, general visceral efferent. The nucleus of the taste and visceral sensory components is the solitary nucleus in the medulla. The nucleus of the general sensory component, which provides sensation to skin on the outside of the ear, is the trigeminal nucleus. The motor nucleus for fibers to the stylopharyngeus is the nucleus ambiguus in the medulla. And the nucleus for the parasympathetic innervation to the parotid gland is the inferior salivatory nucleus in the medulla. The glossopharyngeal nerve emerges from the lateral medulla posterior to the olive and exits the posterior cranial fossa through the jugular foramen. Within the jugular foramen are the superior and inferior sensory ganglia of the glossopharyngeal nerve. The superior ganglion contains the cell bodies of the visceral afferents that travel from the bifurcation of the common carotid artery in the neck to innervate the chemoreceptors of the carotid body and the baroreceptors of the carotid sinus. The neurons involved in general sensation to the posterior 1/3 of the tongue, the mucosa of the oropharynx, and the tympanic cavity also have their cell bodies in the superior ganglion. The inferior ganglion contains the cell bodies of the neurons involved in the special sense of taste to the posterior one-third of the tongue and general sensation to skin on the outer part of the ear. Also within the jugular foramen, the tympanic nerve branches off of the glossopharyngeal nerve and enters the petrous portion of the temporal bone. It ascends to the tympanic cavity and forms a tympanic plexus that provides general sensation to the middle ear. The preganglionic parasympathetics of the glossopharyngeal nerve also run in the tympanic nerve and branch from the tympanic plexus as the lesser petrosal nerve. The lesser petrosal nerve travels through the temporal bone and enters the middle cranial fossa through a hiatus just lateral to the greater petrosal nerve. The nerve exits the cranial cavity through the foramen ovale and immediately synapses at the otic ganglion, which is suspended from the mandibular division of the trigeminal nerve. Postganglionic parasympathetic fibers join a nearby branch of the mandibular nerve, the auriculotemporal nerve. When they reach the level of the parotid gland, these postganglionic parasympathetics leave the auriculotemporal nerve and enter the gland. The motor nerve to the stylopharyngeus branches from the glossopharyngeal nerve as it exits the jugular foramen and runs along the posterior and lateral borders of the muscle before innervating it. The glossopharyngeal nerve continues inferomedially towards the pharyngeal constrictor muscles. The pharyngeal branch leaves and continues with the pharyngeal branch of the vagus nerve to form the pharyngeal plexus. The glossopharyngeal nerve passes between the superior and middle pharyngeal constrictor muscles and terminates in the oropharynx and posterior third of the tongue. Cranial nerve 10, the vagus nerve. The name vagus, Latin for wandering, was inspired by the extensive distribution of this cranial nerve. It carries parasympathetic innervation through the head and as far inferiorly as the abdomen. In addition to this special visceral efferent modality, it also carries special visceral afferent in the form of taste fibers to the epiglottis, general visceral afferent, general somatic afferent, and general visceral efferent functional components. The solitary nucleus is for the taste fibers from the epiglottis and the fibers of the general visceral component, which provide sensation to the pharynx, larynx, trachea, esophagus, and the thoracic and abdominal viscera. The nucleus for the voluntary motor fibers is the nucleus ambiguus, and the dorsal motor nucleus of the vagus in the medulla is the nucleus for the parasympathetic fibers. General somatic afferent fibers from the skin on the external ear are received by the trigeminal nucleus. You've probably noticed that 3 cranial nerves, 7, 9, and 10, have general somatic afferent modalities associated with cutaneous innervation of the outer ear and external acoustic meatus. And in each case, the nucleus for these sensory fibers is the trigeminal nucleus. The rootlets of the vagus nerve arise from the lateral medulla posterior to the olive and converge to form a single nerve that passes through the jugular foramen. The superior, or jugular, and inferior, or nodose, ganglia are found in the vagus nerve just inferior to the jugular foramen. The superior ganglion contains the cell bodies of the general somatic afferent component, which is associated with general sensation to the dura mater of the posterior cranial fossa and to some of the skin around the external acoustic meatus. The inferior ganglion contains cell bodies of the special visceral afferent component, which is taste to the epiglottis, and the general visceral afferent component, which is sensation to the mucosa of the soft palate, the pharynx, and the larynx. Between the superior and inferior vagal ganglia, 3 branches arise from the vagus nerve. A sensory branch to skin on the external ear, a meningeal branch that provides sensory innervation to the dura mater in the posterior cranial fossa, and the pharyngeal branch, which combines with the pharyngeal branch of the glossopharyngeal nerve to form the pharyngeal plexus. The pharyngeal branch of the vagus nerve carries motor fibers to the muscles of the palate, except for the tensor veli palatini, which is innervated by the mandibular division of the trigeminal nerve, and the pharynx, except for the stylopharyngeus, which is innervated by the glossopharyngeal nerve. Near the inferior ganglion, the superior laryngeal nerve branches from the vagus and travels inferiorly. It bifurcates into the internal and external laryngeal nerves. The internal laryngeal nerve pierces the thyrohyoid membrane medially to enter the larynx, where it provides sensory innervation to the mucosa above the vocal cords. The external laryngeal nerve continues inferiorly and provides motor innervation to the cricothyroid muscle, a muscle of the larynx. The vagus continues inferiorly through the neck, giving off cardiac rami that follow the carotid arteries to the aorta, where they form the cardiac plexus. The right vagus nerve gives off the recurrent laryngeal nerve at the level of the subclavian artery, while the left recurrent laryngeal nerve doesn't branch from the vagus until the level of the aorta. The recurrent laryngeal nerves travel superiorly to pass the inferior border of the inferior pharyngeal constrictor muscle to reach the larynx. The recurrent laryngeal nerves provide general visceral efferent fibers to all of the laryngeal muscles except for the cricothyroid, which is innervated by the external laryngeal nerve. The recurrent laryngeal nerves also provide general visceral afferent fibers to the laryngeal mucosa below the vocal cords. The right and left vagus nerves continue into the thorax, sending branches to the pulmonary and esophageal plexuses, and then pass through the esophageal hiatus to reach the abdomen, where they provide parasympathetic innervation to the viscera.
Welcome to another clinical correlation. Now, we went over the physical exam for cranial nerves 1 through 6 in the last cranial nerve lecture. Let's discuss cranial nerves 7, 8, 9, and 10 right now, and then we'll talk about cranial nerves 11 and 12 before the end of session quiz. So, cranial nerve 7, that's the facial nerve. Now, the facial nerve is responsible for much of the motor innervations to the face. So look for any asymmetry. Ask the patient to raise both eyebrows, to frown, to close their eyes really tightly. Then you can have them smile and then finally puff out their cheeks. They love that one. Cranial nerve 8 is the acoustic. So this is where you check for hearing. So you can do this several different ways. You can whisper in their ear and ask if they understood you. I always thought that was a little bit creepy. So I like to rub my fingers together on each side and see if they can hear that very soft sound. If you have a tuning fork, then you can perform the Weber or the Rene test. And they help to determine if a patient has a conduction or a sensorineural deficit. For cranial nerves 9 and 10, so this is the glossopharyngeal and the vagus nerve. Now we group 9 and 10 together when we examine the patient. You want to listen to the patient's voice. So are they hoarse? Ask the patient to say ah, and try to observe that the soft palate is actually rising when they say that. Okay, so let's go over a couple of these questions. A patient is unable to close the right eye completely, cannot raise his right eyebrow, and the right side of his mouth is drooping. Which cranial nerve is most likely affected in this patient? Well, this is going to be cranial nerve 7. This is the facial nerve. Now, this patient is probably suffering from Bell's palsy. I cover this in detail in a clinical correlation for the face and scalp lecture. Next question. Which cranial nerve impacts voice quality? So this is going to be your glossopharyngeal nerve. So this is cranial nerve 9, and the vagus nerve, cranial nerve 10. All right, so let's get back to that lecture.
Cranial nerve 11, the spinal accessory nerve. The spinal accessory nerve supplies motor innervation to the trapezius and the sternocleidomastoid muscles. The only modality of this cranial nerve is usually classified as general somatic efferent, although occasionally some will argue that it is more appropriately called special visceral efferent because the muscles it innervates were thought to arise from branchial arches. Regardless of its classification, the most important fact to learn is that the spinal accessory nerve provides motor innervation to the trapezius and sternocleidomastoid muscles. The trapezius has attachments to the skull, the vertebra, and the scapula, while the 3 attachments of the sternocleidomastoid muscle are in its name: sternum, clavicle, for cleido, and mastoid process of the temporal bone of the skull. It used to be taught, and occasionally still is taught, that the spinal accessory nerve has a cranial root from the nucleus ambiguus in the medulla and a spinal root from a nucleus in the spinal cord. Now, however, it is known that the so-called cranial root is actually part of the vagus nerve that only briefly joins the spinal root. The spinal accessory nucleus in the ventral horns of the gray matter at spinal cord levels C2 through C5 or 6 gives off axons that emerge from the spinal cord laterally between the dorsal and ventral roots as rootlets that converge to form the spinal accessory nerve. This nerve passes superiorly through the foramen magnum and follows the lateral aspect of the medulla. The spinal accessory nerve passes through the jugular foramen and travels laterally to reach the underside of the sternocleidomastoid. After giving off motor branches to this muscle, the nerve continues across the posterior triangle of the neck to reach the underside of the trapezius, which it also innervates. Given its origin from the spinal cord, the spinal accessory nerve is officially not a true cranial nerve, but rather a peripheral spinal nerve. Cranial nerve 12, the hypoglossal nerve. The hypoglossal nerve's sole modality is general somatic efferent. It provides motor innervation to muscles acting on the tongue. The cell bodies of the hypoglossal nerve are found in the hypoglossal nucleus in the medulla. Axons from these cell bodies emerge from the sulcus between the olive and the medullary pyramid as a series of rootlets that combine to form the hypoglossal nerve. The nerves pass through the hypoglossal canals, which begin in the posterior cranial fossa, just inferior to the jugular tubercles, and open superior and anterior to the occipital condyles. The nerve continues anteriorly to reach the tongue, where it innervates all of the intrinsic tongue muscles and the extrinsic styloglossus, hyoglossus, and genioglossus muscles. The other extrinsic tongue muscle, the palatoglossus, is innervated by the pharyngeal plexus.
All right, welcome to the second clinical correlation. Let's go over the last of our cranial nerves, so we're looking at 9, 10, 11, and 12. Now recall that 9 and 10, the glossopharyngeal and the vagus nerve, remember again that we group these two together. We're listening to the patient's voice. Are they hoarse? Ask them to say ah, and then observe the soft palate. And then on cranial nerve 11, that's the spinal accessory nerve. ask the patient to shrug both shoulders upwards against your hands. So you're actually trying to assess them for weakness on one side or the other. Also, you can have the patient turn his or her head to each side against your hand to see if they have good strength there as well. And then we have cranial nerve 12. Now have the patient protrude their tongue. This is the hypoglossal nerve. Make sure the tongue doesn't deviate to one side or the other. All right, so let's answer a couple questions here. When asked to shrug shoulders against resistance, a patient has weakness on the left side. Which cranial nerve may be involved? That's going to be 11, spinal accessory nerve, and the muscle involved is the trapezius muscle. Next, if a patient's tongue deviates to either side when asked to protrude his or her tongue, which cranial nerve could be affected? Easy one, it's the hypoglossal nerve, that's cranial nerve 12. So that covers the cranial nerves. Now I want you to pause the video and answer the end of session quiz questions, and then we'll go over those answers together. All right, let's get going. What cranial nerve is affected in Bell's palsy? So this was again mentioned in my clinical correlation. This is cranial nerve 7. Next question. How do you test cranial nerve 8? So that's going to be with the creepy whisper test. You can also do the little hand thing, the rubbing of the fingers together. And then probably for even better testing, you can do the Weber or the Rene test with a tuning fork. Next, where is the nucleus of taste located in the brainstem? So that's going to be the solitary nucleus in the medulla. Next question, which cranial nerve provides taste for the following areas of the tongue? Anterior 2/3 is going to be cranial nerve 7. Posterior 1/3 is going to be cranial nerve 9. Next question. What cranial nerve is tested by asking a patient to shrug their shoulders against resistance? So this is going to be cranial nerve 11 or the spinal accessory nerve. Next question. What cranial nerve innervates the sternocleidomastoid muscle? Again, this is the cranial nerve 11 or the spinal accessory nerve. Next question. What is the sole modality of the hypoglossal nerve, so cranial nerve 12? This is going to be general somatic efferent. Next question. Which cranial nerve gives off the recurrent laryngeal nerve? So this is going to be the vagus nerve. Now remember from the clinical correlation that one of the ways to test the vagus nerve is to determine if the patient is hoarse or not. However, just because a patient is hoarse doesn't mean that the vagus is the cause of the hoarseness. And now it can be an isolated injury to the recurrent laryngeal nerve, which is pretty common and is a complication of a thyroidectomy. Or it can even be a dysfunction of the larynx itself, as in the case of laryngitis or vocal cord nodules. All right, next question. Which cranial nerves carry parasympathetic innervation? Now remember from the previous lecture that cranial nerve 3 has parasympathetic innervation, and then cranial nerve 7, cranial nerve 9, and cranial nerve 10. Okay guys, we're almost done. We've provided some images for you to label again. Recalling these images in a time setting will help you to perform well on the practical part of your exam. So label these images and then we'll be finished. Thanks.